Good morning. My name is Dr. Beth Shelley, and I have no relevant disclosures to this lecture. I'm going to talk this morning about the physiotherapy assessment of patients with neurogenic bladder, and we're going to look at the whole patient. I have a freestanding practice, outpatient physical therapy in the Midwest here in Iowa and Illinois, and I specialize in all types of pelvic muscle dysfunction. Primarily for neurological patients, I see MS, Parkinson's, and Alzheimer's. We're going to talk about the physical therapy assessment, and I've just listed here the bullet list of the categories. We'll go into each of these in detail. And we always will start with looking at the family and the caregiver availability. How are they available to the patient? In some cases, we don't have caregivers, and therefore we need to keep that into consideration with particular treatments. Also, the patient themselves, as we've heard already, there is a possibility of dementia, and things would be determined in treatment based on the patient's cognitive ability. I will start off with a history intake, looking at the patient's symptoms of urinary incontinence, how predictable it is, what position it occurs in, the circumstances related to it, what their current or past treatments are and bother, as well as the mode of voluntary voiding. What position do they find most successful? Do they have symptoms of hesitancy or obstruction? How do they initiate their void? Are they using some of the intra-abdominal pressure techniques or maybe triggering techniques? And how often do they use their self-catheterization? I have each patient complete a measured volume bladder diary. I think it's very important to have them measure each of the volumes of voluntary void as well as the amount of volume of the catheterization. That gives you a lot of information about their emptying capacity and the results of any triggered voiding techniques. Of course, their intake, the timing, the amount, and the type of fluid, and the occurrence of the leakage. The sensation of bladder filling can vary greatly, and it is sometimes important initially in their disease process for them to be able to discover which of these sensations results in effective voiding. The colored urine test uses a medication called pyridium that turns the urine bright orange. This is especially important in patients with insensible incontinence where they don't feel the leakage coming out. We know that, especially for women, there is vaginal discharge, and for women and men, sweating can make the pads wet. And in some countries and some times of the year, sweating is a real problem with these very big pads. And it makes them feel like they are leaking urine when in fact they are not. So please be very clear that you are dealing with urine, or maybe not. Looking here, you can see this pad does not have any orange on it. That was changed because of wetness not related to urine, whereas this one you can see the orange. And I would encourage you to have them bring the pads into you. It is not the most fun part of my practice, but it is very helpful and important that you are assessing them, not the patient. The neurological assessment would proceed based on the level of patient involvement and include the assessment of sensation with sharp, dull, and light touch in the various dermatomes of the perineum, as well as the reflexes in the area, which can be important also to include the knee and ankle reflex assessment. The physical therapy physical assessment will again begin with the whole body. What is the range of motion of the lower extremities in order to sit on the toilet? If they're very stiff in their hip flexors, they won't be able to sit very easily. Sitting balance is also important. If you are teetering precariously on the toilet, it's hard to relax all the muscles that you need to. Mobility and ambulation to the bathroom. What is the environment that they're ambulating through? How do they get on and off the toilet? And what is the finger dexterity in order to remove their clothing or to manage a catheter? The examination of the pelvic floor muscle would proceed with a digital assessment per vagina or rectum, looking at various components. And this is very complex assessment, which we don't have time to go over in detail. There will be a discussion further of tone in the urological terms workshop, number 25, later on this conference. Hypertonic pelvic floor muscle, of course, is an increased tone, and that can be digitally noticed by the ability to relax after a contraction, the ability to maintain a contraction as you move your finger through the vagina or rectum, their descent of the pelvic floor muscle during a bearing down, and, of course, resting tension. DeVries has a tone grading scale with good reliability, which just basically has three choices. Is it hypotonic, normal, or hypertonic, as you can see listed here? D. Ritter developed a scale in MS patients, which I think is very helpful even for other patients with neurological conditions, spanning from 3, an active relaxation after a contraction, so this would be your normal response, all the way to 1, where you pull and press and stretch the pelvic floor muscle, but it does not let go because the spasm is so strong and present. On the opposite side of the scale is hypotonic, which again is decreased tone, and some of our patients will be working through that process of strength training. EMG assessment of the pelvic floor muscle diagnosis would, of course, be an intramuscular or concentric needle test. Physical therapists do not perform needle EMG testing. We would be performing a surface EMG, which measures muscle activation patterns. Now, surface EMG includes both the rectal and anal probe as well as the perirectal electrodes, and I'll show you the way those are put on in just a moment. We would be looking at the patient's ability to fully relax when they need to, such as during urination and defecation, as well as the ability to contract, as during movements, transfers, or coughing or lifting. The assessment of tone is a little bit more challenging, and ideally it would include a dynamometer or a myotometer. These are not clinically available. So the assessment of tone with a surface EMG has problems. We can only assess the contractile component, so that some patients with a normal SEMG still may have hypertonicity, and this could be through the presence of trigger points or the passive component of tone. Also, the amount that is measured is related to the adipose tissue, hair, scar tissue, and other issues of skin conductance, so it's not a perfect test. Here's a tracing of a hypertonic muscle. In the yellow areas, the patient is being asked to contract, and in the white areas, they are being asked to relax. And you can see the red line is the pelvic floor. This has a difference from this rest to this rest and spikes here that should not be present. The bearing down test is an attempt to judge how the patient relaxes the pelvic floor during the maneuver of bearing down. The normal response is a bulging belly as they bear down with a bulging pelvic floor, relaxing and decreasing the EMG. A paradoxical contraction is when they correctly bulge the belly as they bear down, but the pelvic floor muscle contracts. And this, of course, could lead to obstruction in defecation and urination. The external electrodes are placed, as you see here, perianally with the reference electrode on a bony prominence. The test can be done in lying down, but it's better done sitting on a commode. The normal test would look like this, the red line being the pelvic floor, and this tracing during the yellow, the patient is being asked to bear down. And you can see the abdominal tracing going up, so they are recruiting their abdominals correctly, and the pelvic floor muscle goes down. So the pelvic floor muscle is relaxing correctly. This is not a perfect test, and partly because patients do not want to pass gas or something even more in front of you. In addition to that, if you do the test lying down, it's just not normal. You know how difficult it is to move your bowels on a bedpan? Not easy. Even if they do everything correctly and they're on a commode, EMG artifact can result in an electrode shear, which makes it look like they're raising their activity when they are not. The next test of EMG coordination is during voiding. And in this circumstance, I would have the patient arrive to the clinic with a full bladder and place the electrodes as you saw in the previous picture. The patient sits on the commode with the EMG tracing running. I try to leave the room if I can to allow them as much normal voiding as possible. And this is one of the tracings that you can see a patient of mine was attempting to void, but having spikes of pelvic floor muscle activity during that attempted void. Again, this is not a perfect test. And a recent research study of normals showed that 88% of normals had EMG activity during flow. And this may be because we are measuring primarily the external anal sphincter, not the urethral sphincter, and they are adequately able to relax the urethral sphincter. Not a perfect test, but it is of some clinical utility. So I have shared with you how I would take a history and bladder function through questionnaires, a neurological assessment, mobility and movement testing, as well as the specific testing of the pelvic floor muscle function. The diagnosis, of course, is going to be ultimately made by the physician. And I'm going to make a plea on behalf of all nurses and physical therapists to the physicians. Please share your specific diagnosis with your team so that the other members of the team can take that in context with their treatment in developing an accurate treatment process. Thank you very much. If we have a question or two. Yes, can you come to the microphone? The session is being recorded.
Good morning, I'm Puck from the Netherlands. I was wondering if you know the Maple device.
I am aware, yes. I don't have that in the United States, but I do know that it is better at discerning out artifact and other not correct tracings. Have you used it in either the bearing down test or the urination test?
No, I'm not that familiar with it, but I heard from it from a physiotherapist, so
yes.
I'm here as well to hear about the results of
right,
the device.
And I do know in session 20 at this meeting there are going to be some presentations, and I think the Maple has one of those that is going to look at how it can discern differences during movement. There's one on running, there's one on bearing down, so maybe we'll have some better tools.
Okay, thank you.
Thank you.
I have a question. Do you say that you use pads to know exactly how to determine the severity of the incontinence, and which is I have one, but which is the preferred pad test that you use?
So the pad test is the test, of course, that you are weighing the pads before, and then you have the patient perform some maneuvers, and then you weigh the pads after. I typically use a 1-hour pad test for convenience in the clinic, although I find the pyridium test gives me a little bit better measure of their real life. But in my 1-hour pad test, I will have them perform activities such as jumping jacks or squats. Some of this is limited by their physical capacity, coughing, things like that. Would you like to share your test?
Yes, I usually use the same one, because it's easy, it's normatized, and it gets the same result. It's schematized. Mm-hmm. So, but the problem is that I find I use the same 1-hour pad test, but I I have the feeling that in neurodegenerative disease, the problem is that the patient cannot make me the reality of his 24 hours during that. And maybe we have a lot of patients that have motor disability, and we cannot not be so acquire the method of 1 hour PAD test in front of another patient that call me with incontinence, but not a neurologic disease.
Very true, and that's why I find that measured volume bladder diary to be most representative of their life.
That's
yes.
true.
And there is one other test which I didn't mention. In physical therapy, we have what's called the Get Up and Go test, which is a timed walking test, and that this has been done in patients on the way to the bathroom. So they have a volume in their bladder, and you start the timer go, and they, however they make it to the bathroom, whether that's a wheelchair or a walker or just walking, it's a prescribed distance, and then they will undress and sit down, and the timer stops.
Okay.
And so this is another way that you can objectively define some of their abilities or lack of.
Thank you.
Yes. Yes.
Do you have? There is any question?
Your comment about getting the diagnosis right is very apt. And excuse me, but I wanted to ask a question of the first speaker.
Mm-hmm.
As regards Parkinson's disease opposed to multiple system atrophy, do you find that, because I'm a urogynecologist, so I don't particularly focus on these areas, but I do see the patients. The Parkinson's patients don't generally have that much voiding dysfunction. They usually empty their bladders quite well, but the MSA patients always have a voiding dysfunction. Would you say that's a fair statement?
Yes.
I mean, can you tell a percentage of people with Parkinson's that will have a voiding dysfunction?
Yes, they have.
What percentage would you say?
I don't get to your answer very well.
What percentage of people with Parkinson's would you in your experience?
I don't have the percentage as well,
okay.
but I think that we more than 30%.
Okay, yeah, whereas the multiple system atrophy almost always do.
In MSA, it's always a neurologic dysfunction. With Parkinson, if not, in Parkinson, maybe you have the motor disability that is about the pathophysiology of that of substantia nigra, and maybe cognitive impairment, and urinary disturbance is not so frequently, but it comes with a neurogenic intrusive overactivity frequently. I don't have a real percentage for you.